Hello, everybody. I would like to ask a question. If you can recall a time when you touched a hot surface, either touching a hot pan or sipping in hot coffee, when you burnt yourself, how long did it take for you to react and move away from that pain or that burning sensation? What helped make the pain better? Or have you even ever experienced a different kind of pain, like twisting your ankle or getting a paper cut or having a stomach ache? So today we're going to talk about pain relief that focuses on patient-centered care. My name is Leigh Fadera, and I have been helping manage pain for patients in hospice and palliative care for over 5 years, providing proper pain assessment, involving patients in planning, educating about proper pain management to provide pain relief. So today we will discuss pain, its pathophysiology, characteristics of pain, interventions to help manage pain, including pharmacological and non-pharmacological interventions, and how to manage pain in a patient-centered manner. And we will end our lesson with some questions. So, according to the International Association for the Study of Pain, or IASP, pain is related to actual or potential injury, which causes unpleasant sensory and emotional experience. So going back to having touched that hot surface, our body senses a burn or pain, which damages the skin. If not for pain, our finger would remain in contact with that hot surface and potentially lead to a second or third degree burn. So pain is important. It's a defense mechanism as it warns the body about potential or actual injuries or disease so we can keep our body intact and healthy as much as possible. So once there is stimulus, the body has pain receptors or nociceptors that sends impulses to the nervous system, which relays information to the brain and gives feedback on how to react, either removing your hand from the pot or keeping it there if you don't have any nociceptors or you're not as sensitive to pain. So these nociceptors, or these pain receptors, are present all over the body except for the brain. So the nociceptors could be myelinated or non-myelinated. It matters because it tells how fast the pain travels from your finger all the way up to your brain. So they are connected to that spinal nerves to the spinal cord and goes up to the brain so that the brain can react. Think about when you have burnt yourself, how instantaneous, how fast you removed your finger from that burning, right? Without even have to think about anything. Your body just automatically reacts to it because of how fast those signals from your finger travels to your brain, and your brain reacts and sends signal back to your finger to say, hey, remove it, because it's going to burn you. It's going to cause damage to the skin. So it's a very good defense mechanism. There's also different types of pain. Here's acute and chronic. So we know that acute is less than 6 months. Acute pain is relieved when the underlying problem is cured. And as I've said, it's typically less than 6 months. And chronic pain is usually persistent pain that occurs over 6 months. There's also neuropathic pain, which according to IASP is pain arising as a direct consequence of a lesion or disease affecting the somatosensory system. So it doesn't have to be from a pain receptor outside of the body, from a muscle. It's neuropathic, right? So the central neuropathic pain, it originates from damage to the brain or spinal cord, while peripheral neuropathy originates from damage to the peripheral nerves or nerve plexus, nerve roots, or dorsal root ganglion. What about nociceptive? It is caused by the stimulation or sensitization of peripheral nociceptors or pain receptors, and it has a high threshold for activation and increase their output as the stimulus increases. And there's also psychogenic pain, pain that persists despite the lack of any identified underlying physical cause. It's all in their psyche, right? It's still pain for them. So there's different kinds of pain. There's the somatic pain, pain from skin, muscles, and joints, and there's visceral pain, pain from internal organs. So are all pain the same? Pain from a hot surface is different from the pain felt compared to twisting your ankle or getting a paper cut or having a stomach ache, right? So think about when a patient has a heart attack, for example. Their pain is usually felt at a different location. One of the triggers or the symptoms that a patient having a heart attack would say, I have pain and it radiates to my shoulder or to your arm, right? So this is called a referred pain. As an example, there's that T1 and T5 spinal segments are pain receptors for both the heart and the shoulders and arms. So when someone has a heart attack, the patient complains of pain radiating to the left shoulder and arm because the brain cannot distinguish the pain from the heart. So that is what we call visceral pain and referred pain. So providing symptom management of pain that accounts for patient-specific goals and outcomes can be implemented for the quality and safety education for nurses, or QSEN, which they have a competency, which is patient-centered care. Patient-centered care promotes developing a care based on the patient's preferences, values, and needs to provide a compassionate and coordinated care. Preventing and relieving suffering is the focus of palliative care and supporting the best possible quality of life. Taking care of patients with pain and encouraging their active participation in the assessment, the planning, the implementation, and evaluation appears to have a better quality of life as their symptoms are better managed. In a distressing time of patient's life experiencing pain, it's the responsibility of the nurse to provide and promote high quality care to relieve suffering. So how do we do that? Gaining the patient's trust and developing rapport is significant so patients can openly discuss their symptoms, their behaviors, their challenges, which will be helpful in care planning of pain management. Providing education to patients that pain management is highly individualized, so reporting pain accurately during the pain assessment and proper understanding of the interventions are all vital. Through adequate assessment, the nurse can identify the location of the pain, where the pain is, right? The severity or the type of pain, whether it's acute, less than 6 months, chronic, over 6 months, neuropathic, or nociceptive. We can also ask what the pain feels like, if it's always there, if it's constant, or if it's intermittent. Does it only happen when you do certain positions, certain activities? Also asking about what kind of pain is felt, dull, sharp, ache, throbbing, right? Cramping, stabbing, shooting, tingling. Also the pain rating, using a 0 out of 10 scale. From 0 to 10, can you tell me what rating your pain is at the moment? What is acceptable for you? What is the best pain rating or the worst pain rating? Someone can say their acceptable pain level is 8 out of 10 because they have a high threshold. And some might say, I can only manage 2 out of 10 pain, right? So understanding their rating level at the moment, what's acceptable for them, what's the best and what's the worst it has been, can help guide us as to where we're at, what the patient would like, and what works for the patient, right? This information will be used to plan for the intervention specific to the patient to achieve the goal. The emphasis on patient-centered care can be demonstrated with the acknowledgement of individual patient goals. To continue with pain assessment, you can ask about where the pain is coming from, either from a procedure, from a treatment, from the disease, from injury or trauma or wound. You can also ask pain relief, either medication, what makes the pain better, right? Medication, rest, mobility, massage, hold, hot and cold compress. Or you can also ask what makes the pain worse. It's exacerbated by what? By mobility, by wound care, by rest, by medication. It's really important to understand what the patient is feeling pain-wise and what's going on, what makes it better, what makes it worse, to provide education for proper interventions. So providing patient-centered care after completing a comprehensive pain assessment, asking the patient the goal for pain management is the next step. Your goal should be SMART goals. It should be specific. What does the patient want to accomplish? It should be measurable. How will you know that the goal is accomplished? Whether pain from 8 out of 10 down to 4 out of 10, right? It should be achievable. How can the goal be accomplished? We can't have a patient saying, I have an 8 out of 10 pain. I want it 0 out of 10, 0 out of 10 without any kind of intervention. That might be not achievable, right? It should be relevant. Is it worthwhile for the patient? And it should be time bound. When can you accomplish this goal? So pain is very subjective. Each person experiences pain differently. Some may have a high pain tolerance and some the opposite. Pain medications can work within 30 minutes or others may not work at all. Other interventions could work for patients and others can't. So setting a goal that is individualized would promote patient-centered care. Here's a question. The nurse is developing a plan for patient pain management by determining the level of comfort for the patient that the patient prefers. The nurse would ask A, onset of pain, P, pain rating, C, pain goal, or D, aggravating or alleviating factors. Give you a few seconds or you can hit pause. So the correct answer is C, pain goal. You want to determine the level of comfort the patient prefers. That's pain goal. There are pharmacological interventions. Pain relief is provided to patients with the guidance of the World Health Organization's analgesic ladder to provide adequate pain relief. So we have mild pain for NSAIDs, non-steroidal anti-inflammatory drugs like Tylenol, acetaminophen, right? Ibuprofen, aspirin, the first NSAID that was developed in 1897. So NSAIDs works by inhibiting enzymes from making prostaglandins, which causes pain and inflammation. So it protects some of the prostaglandins, protect the stomach lining from the stomach acid that helps digest food. NSAIDs can cause GI complications. So it's very important to educate the patient about possible GI bleeding. What about moderate pain used for the use of weak opioids, right? And for severe pain, we have potent opioids like morphine, fentanyl. So pain medications, especially opioids, causes sedation, constipation, and addiction. So providing education to a patient about potential side effects is necessary to avoid these complications. Constipation can be easily prevented by adding what? Stool softeners, laxatives, right? Patient can develop some kind of tolerance, which is a state of adaptation in which a drug becomes less effective over time, which means a larger dose is needed to achieve the same effect. Patients could take one tablet every 12 hours, and because their body's tolerant to that medication, now needing one every 6 hours, right? There's also dependence, the state of adaptation characterized by symptoms of withdrawal. When a medication is abruptly stopped, the dose is rapidly reduced. So patients are now unable to function without the pain medications. They become dependent on it. And also there's addiction, a chronic relapsing disease that is characterized by compulsive drug seeking and use despite the known harmful consequences. They're addicted to the medication. They can't stop. So providing education about these pharmacological interventions is necessary so that the patient can understand and choose which medications works best for them. Here's a question. The nurse recommends the patient who is taking opioids to avoid constipation by A, increasing fluids and exercise, B, administering enema PRN, C, using laxative and stool softener, or D, adding fiber to diet. Give you a few seconds, or you can pause. So the correct answer is C, using laxative and stool softener. Other than opioids and NSAIDs, there's also other pharmacological interventions or adjuvant therapy. Adjuvant drugs can be used to enhance the effects of pain medication, to treat symptoms, and provide analgesia for other types of pain. Adjuvant analgesics are particularly useful when evidence of decreased opioid responsiveness is present. So we have antidepressants, or TCAs, are the most tested, including amitriptyline, cypramine, imipramine, and nortriptyline. There's anticonvulsants, anti-seizures. They act by blocking the sodium channels in order to provide pain relief. And the most commonly used one is Tegretol, carbamazepine. There's also local anesthetics, that stops the nerves in a part of your body sending signals to your brain, either the application or injection to a number-specific point in the body, like lidocaine. And there's also cannabis use. The human body has an endocannabinoid system, which has been found to be implicated in pain and other functions. In another study, researchers looked at the effect of smoked cannabis on 30 participants with spasticity due to multiple sclerosis. It indicated that smoked cannabis was superior to placebo in symptom and pain reduction in patients with treatment-like spasticity. Another question. Opioid tolerance is developed when a patient states A, I need to take laxatives to prevent constipation. B, I get anxious before the next dose. C, I have a regular bowel movement. Or D, I need to take more pain medication compared to the last 2 weeks prior. You can hit pause. So the correct answer is D, I need to take more pain medications compared to the last 2 weeks. Other than medications, whether it's NSAIDs, opioids, or adjuvant therapy, there's also different non-pharmacological interventions. there's therapy, either physical, occupational, or manual therapy, which educates the patient in assessing and changing habits and patterns of movement that causes pain and dysfunction. A 2010 review of scientific evidence of manual therapies for a range of conditions concluded that spinal manipulation or mobilization may be helpful for several conditions, including back pain, migraines, neck-related headaches, um, any joint conditions, and whiplash-associated disorders. Another one is ultrasound. It's ultrasonic sound waves applied directly to the skin for the treatment of soft tissue injuries and pain. So it treats the underlying tissue with vibration and mild heat, improving blood flow to the affected tissue. Deep heat, such as ultrasound, can increase the temperature of the tissue 3 to 5 centimeters in depth. Heat has the advantage of inducing relaxation and decreased joint stiffness, muscle spasms, and guarding. It assists in increasing the range of motion and increases superficial circulation. Another is heat or cold compress. The application of heat and cold to reduce pain or promote comfort is a common intervention. Another is dry needling. According to the American Physical Therapy Association and several state boards of physical therapy, dry needling is an intramuscular procedure. So intramuscular manual therapy or trigger point dry needling. It penetrates the needle through the skin without introducing any kind of drug. And other non-pharmacological interventions such as resting, distraction, meditation can also be used. Or it could be a combination of pharmacological and non-pharmacological interventions. So here's a question. A patient with a transdermal fentanyl patch and would like to use a heating pad at home. What education would the nurse include for pain management? A, remove the fentanyl patch before applying heat. B, avoid using a heating pad directly on the patch. C, avoid using a heating pad over the patch is allowed. Or D, cover the patch while using a heating pad. Press pause. Select your answer. So the correct answer is B. Avoid using a heating pad directly on the patch. If your fentanyl patch is exposed to extreme heat, it may release too much medication into the body at once. So using a pharmacological and non-pharmacological pain intervention is okay and appropriate. You just want to make sure to educate the patient to not use a heating pad directly onto the fentanyl patch. So we talked about pain and how it travels after receiving a stimulus, right? From the nociceptors or pain receptors, like a hot surface or damage in the heart, which causes a heart attack. It travels from that source, travels to the brain, so the brain can react either to remove that hot surface or inform somebody of a heart attack. How to properly assess pain. Talked about asking the pain location, type, description, rating, pain source, pain relief, and exacerbation. We also talked about involving the patient with developing a SMART goal, specific, measurable, attainable, relevant, and time-bound. So as an example, the patient's back pain will decrease from 8 out of 10 to 5 out of 10 with the use of Tylenol 1,000 milligrams by mouth 3 times a day, hot compress, and home exercise program within a week. Talked about interventions to help relieve pain using pharmacological, using the World Health Organization analgesic ladder, NSAIDs, weak opioids, and potent opioids, and also non-pharmacological interventions like therapy, ice, hot compress, right? Meditation, rest. After educating the patient of pain and its management, we have to evaluate if the pain relief was achieved. For the goal developed with the patient, did the pain decrease from 8 out of 10 to 5 out of 10? If the goal was met, great. If not, then back to developing a plan that would work. Maybe changing the medication from Tylenol to a weak opioid like tramadol. The center of care is the patient, so the involvement of the patient is important to provide high quality care. Goal setting is individualized because each patient has different needs. Interventions are also specific to the patient because of how different the body metabolizes medications and reacts to non-pharmacological interventions. So patient-centered care provides high quality of care, especially in pain relief. This concludes my presentation about patient-centered care for pain relief. If you have any questions, you can contact me via email, leigh.fadera@student.ctuonline.edu. Again, I appreciate your time and participation. I hope you have gained knowledge about pain management, and hopefully you can apply this knowledge into clinical practice. Again, thank you very much. Bye-bye.